Welcome to Docs on Call, brought to you by Northeast OBGYN, with your host, Liz Schatzline.
Good evening and welcome to the program. I'm Liz Schatzline. Endometriosis is a fairly common problem and it can cause all kinds of difficulties for women. Tonight we're going to look at what some of those difficulties are and ways that endometriosis can be treated. And there are solutions out there, believe me. I'm very pleased to welcome to the program tonight Dr. Jeff Cly. He is an OBGYN practicing at Northeast OBGYN in Fort Wayne. Thank you very much for coming back and joining us.
Thank you for having me.
Now, I said endometriosis is really a fairly common problem. I know a lot of women who have it. What is endometriosis, doctor?
It occurs 10% of the time, so 1 in 10 women have it, and it's the tissue that normally comes out with the period. Somehow, there's a couple different ways, gets inside the body cavity, but outside of the uterus. So it wraps around the intestines, the lining of the body cavity, ovaries, tubes, and every month it kind of has its own little period inside, but it's trapped. So it causes swelling, pain, and inflammation. Sometimes even scar tissue or problems with fertility.
Is there an age when this comes about, or can it happen at any time?
It can happen at any time. A lot of times we'll see the severe cases start when a young woman starts having her period, late teenage years, and marked by severe cramps, severe pain that then gets better as soon as she begins to have the period. But sometimes we do see it in the mid-20s to 30s. But after the mid-30s, usually it's pretty rare to see it start at that time.
Okay. I mentioned that there are solutions to endometriosis. I mean, there are things that women can do, that you can do. This is not something that you just have to grin and bear it, right? You don't have to live with this.
Right. And unfortunately, this is something that's a pet peeve of mine, and I heard this recently, that a doctor told a patient from somewhere else that they just have to live with it, and there's nothing they can do, or it's all in their head. And it's not all in their head. It is a real thing, and we can treat it, and we can make these women live pain-free many times, function normally, get pregnant. And there's so many things we can do for endometriosis nowadays.
Okay. You brought some slides with you, so why don't we go ahead and look at those, and this kind of gives us a better idea of what endometriosis is. What are we looking at, doctor?
The uterus here, ovary on the left, and in the middle is where the period would be. And the period tissue gets out of the uterus, sometimes through the fallopian tubes and sometimes genetically, and lands in the body cavity and causes that little period inside the body cavity where it shouldn't be.
Okay.
And we'll see some pictures next here of endometriosis from a surgery view.
Okay. It's going to bring those up right here. What is this?
Looking at some of the kind of blisters, and those are the clear or reddish endometriosis. Those are earlier lesions that have been maybe a year or less, and they cause the swelling and the pain. And this is inside the body cavity, behind the pelvis, behind the uterus. And we have another shot here of a darker lesion. This one's been there for a couple years, and that's on the right side wall of this person's pelvis. And it shouldn't be there at all. And you can see kind of how it's gathered up. That's just old blood clot that becomes very dark, and we call it a black lesion. And these cause severe pain. Even though it may be only a dime size, it can cause severe pain. So we usually have to remove these during surgery. And then many times the patients feel fantastic after surgery, after we remove these areas.
Will it come back once you take it out, doctor?
It always tries to come back. So then we always have to try to do things, either medicine and hopefully not always surgery, but usually medicine to try to minimize it or prevent it. Additionally, pregnancy helps to prevent it also. So pregnancy treats the endometriosis. So if a woman's around the time when she's ready to have a child, it can be a perfect thing for the endo as well as her family.
Okay, and I do want to mention that Dr. Cly will be answering your questions tonight. If you have questions about endometriosis, the number is 483-8331. We would welcome your calls tonight. Love to hear from you. Is endometriosis dangerous? I know you've said it's a life quality issue, a lot of pain, a lot of problems, but is it life-threatening?
It's not life-threatening, except if a woman has to have surgeries, the risk from surgery could cause problems. Sometimes we see some women have to have repeat surgeries over several years. And so a lot of women will get kind of frustrated, which makes sense. So they might do the surgery, might do some either birth control or progesterone or hormonal suppression of it, but then they just get tired of it. And then for a while it'll seem dormant, but then all of a sudden it comes back because it's been building slowly. Those are the tough cases where there's so much scar tissue that sometimes we can't save the ovary at that point. So I usually recommend not letting it go, always just making sure your doctor is thinking about, okay, how are we treating the endometriosis in view of a person's life and their plans for pregnancy, family, work, career.
Okay, so this is not something that they should just live with, because obviously it can get worse then as it goes along.
Right.
When you say you do surgery, what kind of surgery are you doing for this? Is this laparoscopic, or what are you doing?
Usually that's the last resort, or something where we can't treat it with medicine. And it's a laparoscopic surgery, small incisions, going home the same day. And we usually do not want to take out organs. And it used to be thought that, oh, if you had endometriosis, you had to have a hysterectomy.
Right, just take it all out, right?
And that's absolutely not the right way to go in the beginning. Maybe after a woman's had her family, we can talk about taking things out. But in the beginning, we have so much other things we can do other than a hysterectomy.
Okay, and we have someone on the line who's waiting to ask you a question. Karen, good evening and welcome to the program. You're on the air.
Yes.
Yes, go ahead.
Thank you. I've already been treated for endometriosis. They did the medicated menopause route because I was not able to have any kind of surgery. It was on my intestines, my stomach, and other places it shouldn't be. I don't want to go that route again, and I know that it's back. I can tell by the pains that I'm having. Are there other options?
A great question, and it does come back. And someone in my family, when I was going through med school, went through the same thing, and that's the first time I had realized or known anyone where to come back. So once again, we want to try to suppress it. And you can try some medicines to try to suppress it before your doctor may talk about surgery. One thing that can work is something called Depolupron, and it suppresses your female hormones, suppressing the estrogen in your body, which is what feeds the endometriosis. And sometimes by taking the Depolupron injection, it's a 1 or 3 month injection, doing it for 3 or 6 months ideally, can cause all the improvement that you're looking for, get rid of the pain, suppress the endometriosis, and then after that going on some type of a suppression hormonal manipulation so that you try to prevent it from coming back.
Okay, all right, very good. We have another caller waiting. Diane, good evening and welcome to the program.
Hi there.
Hi.
Nice to have you guys on to give us this information. My question is, can you have a ruptured cyst due to endometriosis? And also, once that is taken care of, is it true or not that endometriosis can spread throughout the body other than the pelvic region?
Well, yeah, two questions. So the first part is you can have a ruptured cyst, an endometrioma, which means you have that, you saw that blackish kind of stuff on that picture. It gets inside the ovary in a cyst, and then it can rupture and leak out, causing a lot of pain, potentially even scar tissue. So if you have something, a cyst and endometriosis, it's important to try to get that out of the ovary, including the wall of the cyst. Imagine like a balloon. You got to get the balloon as well as the liquid, if it was a water-filled balloon, out. And that takes care of that cyst right there. But as I mentioned earlier, endometriosis always tries to come back. And can it spread to the rest of the body? Usually not to the rest of the body. Rare cases it has been found in the lungs. I have one patient right now who has been in her lungs. That's the first patient I've seen with
really?
that.
I didn't know it could spread like that. I always thought it was just a pelvic problem.
Very rare. First time in 15 years I've ever seen that.
Wow.
Have seen it in the belly button, but more commonly around the pelvis. And it can spread to the bladder, and a lot of patients get bladder pain. They have increased urinary frequency, waking up at night to pee multiple times. Usually these women are the ones who, in your family, they always are in the bathroom every 20 minutes.
Yeah.
They've got kind of an endometriosis picture inside of the bladder.
Okay, all right. We have another caller waiting. Joyce, good evening. Welcome to the program. You're on the air.
Yes, I am 60 years old, and I just had a complete hysterectomy, and I would like to know if I need to continue to have yearly pap smears every year.
A hot topic right now, and especially with the insurance and all the changes, it's very important to go for an annual checkup, meaning the breast exam, the heart, lungs, and the pelvic exam where the doctor feels inside to make sure that your uterus or ovaries are normal. But if you don't have a uterus or ovaries, it's still important for the doctor to feel to make sure there's no other abnormalities inside. So you do need to go every year, but you may not need the pap smear, which is that brush where they check the cells of the cervix or the vagina. Check with your doctor on that because it depends on your history. But still, the visit is important every year. You just may save on the $50 or $60 pap smear.
Okay, all right, very good. We have another caller waiting. Ellie, good evening. Welcome to the program. You have a question for Dr. Clyde tonight. Hello, Ellie?
Yes.
Yes,
hi.
go ahead. We can hear you.
Yes. I had a partial hysterectomy in 2004, and they had found a endometriosis and stuff, and then they turned around in 05 and removed the rest of my female organs, and I still have the endometriosis. It's in my pelvis and it causes severe pain in my stomach. Is there what should I do about that?
Wow.
Thank you for your question. And that's unfortunately a common thing we find, whereas a lot of patients will be told or think that once they have this clean out that everything's fine. And a lot of times it does come back. Yes, you can do a lot of things, Ellie. Some medicine can help suppress the endometriosis. The Depolupron I mentioned earlier, progesterone can make a big difference. It's probably in your bladder. You may notice some bladder symptoms which cause increased urination, pain with urination, small volume of urination, even pain with intercourse. So check with your doctor because there's a lot of things you can still do to help you feel normal again.
So even though you've had a hysterectomy, there's still tissue in there, and
Right.
it's
Right.
vulnerable to endometriosis.
Yeah, in that one picture we show with that black little area, that wasn't on the uterus. That was on the patient's side of her pelvis. So if you think about what did they take out, they took out the uterus, but still the endometriosis wasn't in that spot, and it's usually not on the uterus. So if we're kind of trying to change the thinking, and certainly it may be appropriate with endometriosis to do a hysterectomy, but it is not an automatic knee-jerk response.
Okay. I have a quick question before
Sure.
we go back to the phone lines. The medications that you give women to try to treat this, are there side effects from those medications, doctor?
There can be. The Depolupron is a medication that turns off a woman's hormones. So the woman goes into a temporary menopause during the time that medicine is working, from 1 to 3 months, depending on the injection.
Okay.
Usually patients, their pain goes away, but they have some menopausal symptoms which we counteract with some progesterone typically. So a lot of times I find that patients no longer suffering from pain, they are having some difficulties with some hot flashes, night sweats, but overall they find it's a big benefit compared to how they were living before.
Compared to the pain that they were having before,
Right.
the night sweats are nothing, right?
Right, and then afterwards we need to, after that goes away and their body comes back online, we need to suppress their menstrual cycles because usually that's where the pain builds up.
Yeah.
So we'll try to suppress a woman's cycles to have only 3 or 4 of them a year by using either contraceptives or hormonal manipulation so that they can live normally for the majority of time for the rest of their life or until they want to get pregnant again, if that's a choice.
A lot of women may not think that's healthy to only have 3 or 4 periods a year. Is there any problem with that?
No, it actually it seems unnatural, but
Right.
what the hormones do is they kind of make the body think that it's pregnant in a generalized terms, and so it's not producing the menstrual tissue. So there's no blood being built up, so to speak. A lot
Right.
of people think, well, where's it going to go? It's not being put there in the uterus, so that's why it's suppressed until you go off of that hormone.
Okay. All right, let's go back to the phone lines. We have another caller waiting. Good evening and welcome to the program. You're on the air. Go ahead. We can hear you.
Hello.
Hello, caller? Hello? Well, maybe we lost that caller. Hopefully we'll get them back
Sure.
soon. How do you diagnose endometriosis? Because you've talked about symptoms that women have, but how do you diagnose it? Do you do x-rays, ultrasound? What do you do?
It can be challenging because the only true diagnosis is to take a biopsy of it, which the only way to get that is to do surgery. But we'll usually do a diagnosis of exclusion. We'll look at symptoms. So we don't automatically have to jump into surgery right away. So we'll look at the symptoms. Classic symptoms are the week before menstrual cycle, a woman's feeling pain, pressure, sometimes so much nausea and vomiting because of the pain and pressure, cramps. And then when she has her period, those symptoms start to decrease and go away. So that's kind of the classic picture.
Okay.
So we'll kind of try to use symptoms and try to treat with non-surgical methods first.
All right, very good. Now we do have a caller waiting, and they've told me she is there. Kay, good evening.
Hello?
Hello.
Hey, okay, go ahead. I'm sorry, Kate. Go ahead. I'm sorry. Go ahead.
Hello. My nephew's girlfriend has had an endometriosis problem since she was about 14. She's 19 now, and all the doctors are telling her, she's been to several doctors, and they're telling her she needs a hysterectomy, but because of her age, they won't touch her. And she can't seem to find any other relief from this problem. She's got severe scar tissue, but nobody seems to be able to do anything for her.
Boy, 19, that's awfully young.
I agree with, I think what you're saying is I don't like the option of hysterectomy at 19. I've seen some patients who've had those hysterectomies and now they can't have children and they're really still suffering from endometriosis, but now they can't have a family. So what I would recommend is for her to call someone who deals with endometriosis a lot. In our office we deal with a lot of endometriosis, and look at other alternatives, because I'm betting that even though she's had this 4 or 5 year history, I'm betting she hasn't been offered all of the solutions, that some of which we're throwing out tonight. And why that is, I don't know. We're trying to do these programs to teach patients and doctors about the endometriosis, but some of these medicines work so well and can help potentially have her live a normal life. If she has that much scar tissue and adhesions, maybe she needs to have a clean out, but right after that go into the depot-lupron potentially. And the way I explain it to patients is, if I do surgery and I visibly will remove the endometriosis that I can see, that's just like pulling the weed out of the garden. I haven't really dealt with the roots. I've taken care of the leaves that I can see, but the microscopic endometriosis is still there waiting to come out. And that's where the depot-lupron therapy works, because it then kills all the roots. And that's, you got to really use things in combination. But if we just piecemeal it, we do surgery here, we try medicine there, we're not really doing the patient justice.
Yeah, and at 19, you just don't want an all or nothing option in front of you. That's awfully young. So,
exactly.
Okay, good. Hopefully she can find an answer.
Yeah.
We have another caller. Peggy, good evening and welcome to the program.
Good evening.
Hi.
I'm going to turn my TV down.
Okay.
Yes, my question is, 10 years ago I had a hysterectomy and they took out both ovaries. And I tried the hormone replacement therapy, which didn't work, which I had endometriosis. Does that aggravate endometriosis if you are on hormone replacement therapy?
Good question.
Right. It's a fine line. We have a balancing act where we want to give just enough estrogen and or progesterone to help with your symptoms, but not enough to try and trigger the endometriosis. And usually we can walk that balance very well. And I will tell you, I heard you said the hormone therapy didn't work. There is hormone therapy that works for every woman. It's just a matter of finding it. There's so many different brand names. There's so many different pharmacies. There's bioidentical. There's natural. There's animal-based. So don't give up. Just talk to your doctor about who he or she would recommend to help them fine-tune your hormone needs, because I'm sure you can find that answer that's going to make you feel better, but not yet trigger that endometriosis and still help suppress it as well.
Okay, very good. We have another caller waiting. Esther, good evening and welcome to the program. You're on the air. Hello, Esther?
Yes.
Hi, go ahead. We can hear you.
I have a question. Yes.
Go ahead.
Okay. I've just been diagnosed with enlarged uterus, and I had a cyst on my ovary, and I just did a D&C. The doctor says that I'm going to need a hysterectomy, and when I was researching, I found out that there is another process you call embolization. I wondered if you have this in their office, and how much can it help my problem?
Well, yeah, I have a lot of questions coming to my mind of hearing what you're saying, but I think yes, I think you're talking about an endometrial ablation, which treats where the menstrual cycle comes from. So it doesn't treat endometriosis. It helps decrease bleeding and helps decrease cramps to a certain degree with your periods, and it can be done in the office. And it can be done in the operating room or surgery center. And it's a pretty minimally invasive option to help with cramps and bleeding. So yeah, I think there is an answer you're looking for, and and I would continue to look at all your options.
Okay. All right. Very good. We have Pamela standing by on the line. Good evening, Pamela. Welcome to the program.
Hi.
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 Go ahead. We can hear you.
My question is, I'm 38 years old, and for the last 5 or 6 months, I've had really bad problems with my menstrual cycle as far as like the first 2 or 3 days and the clotting.
Mm-hmm.
Is that a sign of the or should I have that checked out, or?
Okay. Is that a sign of endometriosis?
Great question. And she mentioned she, I think, was 36 and
38.
38 and just starting. And there is a condition that we haven't talked about yet that women get in their 30s and sometimes 40s, where they get little glands, instead of inside or outside the uterus, it goes into the uterine walls. And it's kind of like endometriosis inside the uterus itself, causing very bad cramps and many times bleeding with their periods. And the name officially is adenomyosis. And that could be what's going on with her, especially since it's starting. So I would get it checked out, and there are solutions to help you with that problem. Another thing that a lot of people don't realize is they may just start having these urinary problems. Maybe the periods are kind of crampy, but they've always kind of lived with that. And all of a sudden they notice that they're waking up several times a night to urinate. They go to the bathroom during the day a lot, but not much comes out. They have pain with intercourse. It could be that they have endometriosis, and it's manifesting in the bladder with overactive bladder syndrome. And we usually treat that together. It's important to look at the uterus and the bladder as we treat that overactive bladder syndrome. And many times we'll work with urologists also in many cases. But it's looking at that whole picture is very important, not just this body system or that body system. We've got to look at the whole picture.
The plumbing's all connected,
Right,
and it makes its way around through
Yeah.
there. Okay, we have another caller waiting. Michelle, good evening. Welcome to the program. You have a question tonight.
Yes.
Uh-huh.
I'm a 46-year-old woman, and I have had some problems with having cycles. I mean, not having cycles. I haven't had a cycle for 4 months. And I just wondered if that's something that's related to menopause. I'm still having cramps, like I want to start my cycle, but I haven't had one for 4 months.
It's important to have regular cycles after a woman's in her late teens. The late teens, the cycle's just getting started, so it's okay to have irregular cycles. But after that, it's important. So I would check with your doctor to kind of see why. Is it perimenopause, the early stages of menopause? Maybe. Is it just missed ovulation, and so you're having some irregular cycles? That's also possible. But yeah, check with your doctor. I would recommend getting something done so that you're having more regular cycles, or they're maybe giving you some progesterone to make you have a regular cycle. But keeping regular is important to prevent abnormal cell buildup in the uterus, which could cause problems down the road.
Okay. If you have endometriosis and you become pregnant, can it cause problems with the pregnancy?
No, not at all. It
No?
actually would. Pregnancy would help suppress it. So the main problem would be if they couldn't get pregnant, worrying that it could be in the tubes.
Okay.
But once a woman's pregnant, it's past the tubes, it's back in the uterus, and those hormones of pregnancy will actually suppress that endometriosis, and she will do a lot better at the end of it.
Okay, we're going to try to get one more caller in here. Nancy, good evening and welcome to the program.
Hello.
Hi.
I was just curious. I am pregnant right now. Dr. Clyde knows me. I was just wanting to know, how soon after this pregnancy should I be concerned about my endometriosis coming back?
Oh, good. There's a good question.
Sure. Thanks for calling, Nancy. Nancy is one of my longtime favorite patients, and I didn't pay you to call, Nancy. But thank you very much. But what we'll do is, as soon as Nancy delivers, around 4 to 6 weeks after, we'll start something to prevent the endometriosis from coming back as best we can. And many times the medicine that we use will work with breastfeeding.
That was going to be my next question. Does that rule out breastfeeding? You say no.
No, absolutely not. So breastfeeding helps because it suppresses the period, and some of the progesterone medicines help, which suppresses the endometriosis. So the two work together, and actually you're gonna do great.
Okay.
And I appreciate you calling.
Now, I know you are going to be talking about endometriosis a little bit more next week. Tell us about what's happening.
Well, we do a thing called intuition in our office. It's open to any patient, male and female. Spouses are welcome. And I'm going to be talking about endometriosis, going through kind of a slide presentation, these various subjects and answering questions. So anyone who wants more information either for themselves, their partner, or even a daughter, please come. And it's about an hour long. We usually do have refreshments, no charge to it at all, but it's a service to try to help educate. And part of the job is to help educate patients so that when you go see your doctor, that you have some information and you can make a more informed decision.
Okay, and there's the slide that's up, 7 o'clock. August the 11th, you'll be talking a little bit more about this. And thank you very much for coming and talking about it tonight. What is the thought that you want to leave with women tonight about endometriosis and this problem? What should they take away from this show?
Takeaway is it's not in their head, it's real, and there is so much we can do to help them. And if your doctor throws up his or her hands and doesn't know what to do, please don't give up.
Has that been the standard treatment?
That's been the standard treatment.
Okay.
I don't know what to do with you, or we got to take everything out.
Yeah.
But call another group in town. We need to kind of help each other, and don't live with it because you don't have to.
Okay, very good. Dr. Jeff Cly, thank you so much for coming and joining us tonight and talking about this. And I am glad you were here. I hope you'll be with us 2 weeks from now. We won't be here next week, but in 2 weeks, our guests will be Dr. John Crawford and Dr. Brian Chang. They are going to give us an overview of radiation oncology in Fort Wayne. They are with Radiation Oncology Associates. So that is in 2 weeks right here on Docs on Call. Until then, I'm Liz Schatzline. Thanks so much for watching. We'll see you again in 2 weeks. Have a good night.